Okay, now we're going to talk about your thyroid gland. So your thyroid gland lies right here in your neck, and you can actually palpate your borders of your thyroid gland if you just kind of tilt your head back a little bit and then just press kind of gently. Sometimes you can push your thyroid from one side to the other and you can feel the little butterfly shape underneath there. Okay, that's your thyroid gland. And it's in control of all things cellular metabolism. Um, with this medication, it helps to regulate your temperature, growth and development. It helps to affect cardio, respiratory, GI, and neuromuscular. You have to have a functioning thyroid gland. You got to have these hormones in your body, or else you're just not going to make it, people. So, just to review, remember this: from the hypothalamus gland, it sends hormones down to the thyroid gland, tells the thyroid gland, hey, I need you to make some T3 and T4, and then the T3 and the T4 leave from the thyroid gland and go and hang out in the rest of the body. So again, here's just kind of that same neurotransmitter kind of a pathway thing. A couple of things I want you to know about your thyroid gland is that it does have two different types of cells in it. You have a parafollicular cell, which is the one that helps you to regulate your calcitonin. That's the hormone that helps to keep your calcium in homeostasis. And then the follicular sides of those cells, those are the ones that help to secrete the thyroid hormone. You have two different types of thyroid hormone. You have thyroxine, which is T4, and then you have triiodithyramine, that's why we call it T3 also. Both of these guys need to have iodine in your body in order to be processed and to be made. So if you have someone who has an iodine deficiency, then they won't make these hormones. We get most of our iodine from the salt that we eat. A lot of our salt in America, when you read on the bottle, it says iodized salt. So we usually get plenty of that. T4 makes up the majority of the hormones secreted by your thyroid gland, but basically once it gets into your body, it changes from T4 into T3 as it gets a little bit further down the tree, and then that's T3 is what actually acts on the organ. Again, this is one of those systems that works off that negative feedback. Your body's constantly monitoring to see where we at cellularly and metabolically, and to make sure that we got not too little, not too much, but just right. Okay. Your T3 and T4, whenever it leaves the thyroid gland, it cannot just go out anywhere that it wants to and do whatever it wants. It has to hook up with something called the thyroxine binding globulin. It's a big, huge protein-based molecule that runs around the body. It scoops up T3 and T4 and then basically takes it where it needs to go. Did you see what I said? It's a big, huge protein molecule that reaches up and takes T3 and T4. It's a big, huge protein molecule. The reason why I keep emphasizing that is that if we have tons of patients that we treat on a regular basis, our elderly patients, patients that are malnourished, patients with liver disease, patients who may have an altered albumin, an altered protein level in their body, that may mean that their thyroid gland is not going to work appropriately. So be thinking about those types of patients when we're looking for them. So the first two diseases that we're going to talk about, hypothyroidism and hyperthyroidism, I will tell you, I am making this as simple as I possibly can. In the wide world study of endocrinology, we can get really fancy when we talk about thyroid disease. But for the most part, we're just going to say hypo and hyper, and I'll show you a little bit later on why I say we're just going to say hypo and hyper and be happy about it, okay? Sometimes I find whenever I have a disease that's got like a yin and a yang side to it, a hypo and a hyper, is to put those symptoms side by side so I can really take a look at them and kind of process them and put them into my brain. Okay, I want you to start thinking about this like this right now. Hypo means low, 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 low. They're slow speech. They got a puffy face. They have a slow pulse. They're gaining all this weight. They're just slow about everything. Versus a hyperthyroidism, they're always hyper. Okay, they're sweating, they're nervous, they've got weight loss, they've got palpitations, they can't stop moving, they're just heat and tolerant. They're always like, oh my God, are you hot? I'm hot. Okay, versus my hypothyroid patients who are reaching for the blanket all the time. And they're reaching for a blanket or a heater when all the rest of the world is just fine. That's what makes me think about these patients as well. They have a real cold intolerance. Versus my hyperthyroidism patients, because they are just metabolizing so fast all the time, just all the time. They're just hot, 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 hot. okay? And it's because their cellular metabolism is really revved up because they've got way too much hormone in their body. So let's break this down one by one and let's talk about each one of them. Let's talk about hypothyroidism first. I will say that in 19 years of nursing, I see probably more hypothyroidism than I do hyperthyroidism. The most frequent thing that happens is that patients develop an autoimmune disease called Hashimoto's thyroiditis, and basically autoimmune means that it goes in and it attacks the thyroid gland and we really don't know why, okay? These patients present to the clinic typically. They usually don't come to the emergency department, or maybe you see them in clinical practice in the hospital, but they'll have like a conglomeration of a lot of these symptoms. A really smart provider will order a TSH level on this patient. And what we're looking to see is with a high patient who has hypothyroidism, okay, their thyroid stimulating hormone is like, I need T3 and T4 now. And it's so that level gets really, really high. What makes us call it hypothyroidism is when we look at the physical lab levels of T3 and T4, they're both low. So that's what makes it. So when you look at TSH, you're like, but it's hypo, Ms. Hardy. Shouldn't it be low? No, Hypo, okay, remember the thyroid stimulating hormone, all it does is it comes down from the thyroid gland to the gland and says, make me T3 and T4, make me T3 and T4. So it's really high because the body is screaming for T3 and T4. But when I look down at the physical levels of T3 and T4, that's what's low, okay? All right, got it? Good. So in the United States, back in the early 1900s, we had something called the goiter belt. So the goiter belt was a time in American history before we had iodized salt, okay? So if you look on your salt preparation right now and you look at the bottle, it'll usually say iodized salt. Well, before the 1940s, we didn't have iodized salt, we just had plain salt. The reason we added iodine to that salt was because all of these patients who lived in the goiter belt were always hypothyroidic. Let me show you why. So what this goiter looks like, this is what it would look like in a developed country, like something that would look like here in the United States, versus if you were in an undeveloped country where they didn't have iodized salt, that's more what it would look like. So what happens is that as the hypothalamus is telling the thyroid gland, make more T3, make more T3, T3, T4, I need more, right? Okay, so it's telling it all that. So what happens is because the thyroid stimulating hormone is trying to stimulate the thyroid gland to make T3 and T4, that gland in their neck can get really large and can begin to pop out on one side, pop out on the other, it can pop out this way. I'll never forget, I had this sweet young thing. She came in one day and she was holding a bag of peas to her neck. And I said, honey, what's wrong with your neck? She goes, I got a big old huge bump. I'm like, okay. I said, let me see. And sure enough, she pulled the peas down. There's a big old huge lump. But what that lump was a goiter, okay? That lump didn't just come up, okay? She just noticed it, okay? She was at her hairdresser and she popped her hair back, and when she was braiding her hair, and whenever that hair popped her head back, the hairdresser goes, girl, what's wrong with your neck? Sure enough, there was a big old goiter right there, okay? So typically, patients who live in cooler climates need more, have more TSH stimulate, need more T3 and T4 in their body because their metabolism's already higher because they're cold, and so they have more of a metabolic demand. So what happens with patients who are living in the goiter belt, okay, they didn't have iodized salt, they were always cold, they had an increased metabolic demand. So they didn't have enough iodine in their diet to make enough T3 and T4, so they all developed goiters. Whenever the United States came in and started putting iodized salt as the plain old table salt, boom, all the goiters problem went away. We'll still see goiters on occasion in this patient population. You can see them in both patients who have hypothyroidism and patients who have hyperthyroidism. Because again, as the brain is telling the body to make more T3 and T4, that gland can get hypertrophied or enlarged, okay? So some people will tell you, oh, you only see a goiter in hypothyroidism. That's not true. Oh, you'll only see a goiter in hyperthyroidism. That's not true. You can see in either one. It just means that the gland has hypertrophied. It's gotten larger in response to trying to meet the metabolic demand of the body. So you can see a goiter either in hypo or hyperthyroidism. I just wanted to bring that concept up so that if you see a weird lump in someone's neck, that you're thinking about the thyroid gland whenever you look at it. Okay. You also too, the only one thing I want to bring up is now that I've told you that patients who live in colder climates have a higher metabolic demand, and so we need to be screening for hypothyroidism or hyperthyroidism in them more frequently because they have this increased demand. Remember that our patients travel all the time. I just got back from a class reunion, had a long talk with a guy who spent almost 2 years living in Antarctica on a research base. So again, you just never really know where people are at or what they're doing. So you really have to kind of dig down and kind of think about what's going on. Okay, so let's talk about the treatment for hypothyroidism. So the treatment for hypothyroidism is going to be levothyroxine, but I want to make one more comment about our salt intake. So this is the salt that comes from my kitchen, and you can see here that's marked as iodized salt. Well, this is also a salt that comes from my kitchen, and it says canning and pickling salt, plain salt, nothing added. So this salt doesn't have iodine in it. One of the interesting things that's kind of come up recently in a couple of different medical reports is that they're wondering if we're not going to see an increase in the amount of hyperthyroidism related to deficiencies in iodine again. And the reason being is because the American way is that we're eating more in restaurants, and typically restaurants do not order iodized salt. Instead, they're using like sea salt or Himalayan salt, something like that doesn't have the iodine added. So just wanted to put that out there for any of you guys who are eating out more than you're eating in. So with our levothyroxine, this is our medication. We give it to patients in micrograms. It increases both the T3 and the T4. And then we always want to go low, slow, and then ramp up and get the patient to a therapeutic level with this medication. Typically, there's a calculation formula to figuring out what the maximal dose would be, but instead, we need to start slow and then gradually titrate up over days or weeks. Sometimes whenever we take a patient who has hypothyroidism and then we make them normal again, it can make them feel really uncomfortable. They're used to their body kind of running at the speed of a sloth, and then all of a sudden they start running at the speed of a normal human. It can be uncomfortable. That's one of the reasons why we go low and slow. The other thing is too is that it can help to identify some underlying cardiac issues that may or may not, that may be present. Because if you're all of a sudden you're ramping up the cellular metabolism, it may throw them into an arrhythmia. A lot of times whenever we have patients who are on levothyroxine therapy, they tend to be older and they tend to be female. So in our elderly patients, whenever we're given levothyroxine, again, the formula that we use in order to compute that dose may say this patient needs to be at 200 micrograms, but we may reach effectiveness at 50 micrograms or 25 micrograms for that patient. So couple that thing. The other thing about, we have some nursing pearls and I want to share with you on the next slide. So a couple of things that you need to know about this medication. Number one, it's always given in micrograms. We would like for the patient to take the medication 30 minutes before their first meal of the day on an empty stomach with just a clear glass of water and nothing else. I will tell you that getting a patient to wake up at the same time every single day and take their medication with a clear glass of water and wait 30 minutes before they take anything else is a challenge. So in order to help to increase compliance, what you can ask your patient to do is that they need to take it at a consistent time every single day, with food, without food, we don't care, we just need it to be consistent. If the easiest thing for them to do is to take their pill as they're marching out the door with their pill in one hand and their pancake and sausage on a stick on the other, great. Because the key here is to be consistent with how they're taking it, whether with food or without food, and it needs to be at the same time of day every day. We typically tell patients to take it at the beginning of their day. So if you're a night shift person and you're working night shifts, then maybe you need to switch your dose to take it right when you go on for your shift versus when you take it whenever you get off your shift in the morning. So again, just be thinking about those types of things as we're helping these patients to go forward. We need to teach our patients about hypothyroidism that have been diagnosed with it, about hyperthyroidism, because we can swing the patient the other way. We've been treating them for hypothyroidism, we give them this medication, and then all of a sudden maybe it's too much. And so because of that, they begin to become show symptoms of hyperthyroidism. So important that we make sure that we are correcting them, that we're giving them the good teaching that says, hey, if you begin to have any signs of hyperthyroidism, please let us know so that we can make sure that we can treat you appropriately. We want these patients on lifelong therapy. Eventually, you can go so incredibly low that you develop something called a myxedema coma. And we'll talk more about that in a few minutes. The other thing is, for all the ladies that are diagnosed with hypothyroidism, we need them to understand that whenever they are pregnant, that they're going to have an increased amount of cellular metabolism, and we'll need to increase their dose of levothyroxine. So for those patients, really important that their OB know that, one, that they're being treated for hypothyroidism, and that the moment that they get pregnant, they need to be calling their doctor to get their dosage increased so they make sure that they can keep a healthy pregnancy. Here's one of those really fun slides. I really like these slides because they kind of help for me to kind of set it into my brain about how this medication really needs to be going down. I will tell you that whenever the patient takes the first dose, they're not going to feel anything, but by that 6th day, they're going to really start to feel the effects of the medication. And again, the problem with these patients is that sometimes they didn't know they were feeling bad. Sometimes they do, but sometimes they don't. And then as they begin to miss doses, that's when those effects are going to come back again. So very important that we get them just right. The whole Goldilocks principle. Not too high, not too low, but just right. Myxedema coma is something that happens. It's a very rare occurrence. But with these patients, they come in and they are so low. Their TSH will be sky high, their T3, their T4 will be rocketing to the bottom. They come in with kind of just not looking right. They may come in with mental deterioration. Remember, I told you, you cannot be crazy until you're healthy and crazy. So if I have a patient come in and I think that their mental status is off, this is one of the exams that you'll frequently see providers order in order to make sure that, this patient is healthy. If it's a myxedema coma, and what we're seeing is there's really super low T3 and T4 levels, if we replace the T4, then their augmentation, their cognitive level, their ability to think, speak, hear, and talk may all be coming back to normal. Typically with these patients, they are admitted into ICU so they can get that IV replacement of T4. They're usually not like intubated or anything, but they can be pretty sick and really, really confused. So again, always treat patients who are confused with very gentle hands. Guys, it's not their fault that they're confused. It may be a medical diagnosis and what's causing them to be a real pain in your nursing patootie. Hyperthyroidism. So hyperthyroidism can get complicated. The reason it gets complicated is because there's lots of different types of hyperthyroidism. So like hyperthyroidism would be like the big heading, and then we have all these different ways of looking at hyperthyroidism. So with patients who are malnourished, liver impairment, or have protein malnutrition, they have a larger need, have a larger percentage of free thyroid hormone and can lead to hyperthyroidism. So again, I look at those patients and I say to myself, are you hyper or hypo? Where are we at? Okay. Here's all the signs and symptoms. I will tell you, I feel like it's probably easier to see a patient with hyperthyroidism than it is with hypothyroidism. And I know that sounds kind of weird, but I'm just telling you, like, these patients are like, their eyes are all bugging out their heads and they're always moving and they can't be still. So sometimes I feel like these patients are a little more easy to pick up out of a crowd. Sometimes I'm like, wow, is that patient like hyperthyroidic or are they on methamphetamines? I mean, that's really what it looks like. So again, don't memorize this chart, but I just want to point out to you how complicated they get. This is an algorithm whenever we're trying to diagnose hypothyroidism that kind of says, okay, where are we at? What are we doing? What does this patient really, really need? So again, just wanted you to see this. The most common reason why we have hyperthyroidism is Graves' disease. So it's kind of the level of that we'll see. Don't memorize this. I just want you to know that that's what providers are looking at. They're following an algorithm every time they have a patient come in with hyperthyroidism. So here's the hyperthyroidism that gets confusing. So if patients who have hypothyroidism have a high TSH, because their TSH is like, make me some T3, make me some T3, make me some T4, make me more, make me more, make me more, right? Okay, well then that TSH is really high, T3 is low. Okay, got it, hypothyroidism. Do you see how screwed up people with hyperthyroidism can get? It can get complicated. Here we have a low TSH, but we have a normal T4 and a normal T3. Why? That doesn't sound like it's hyper. Like I don't understand. They're complicated. Okay, so again, just want you to know that hyperthyroid patients are complicated. We typically will see them headed over to endocrinology, and endocrinology will give us specific instructions as nursing as to what medications they need to have. So we kind of have two different ways of treating hyperthyroidism. We either suppress it or we kill it. And what I mean by kill it is that we kill off part of the thyroid gland. So a lot of times the problem is that we have an overproduction of the thyroid stimulating hormone. It's just like, make me T3, make me T3, make me T3, make me T3, and it's not listening, okay? It's not listening when the body says, we've got enough T3 and T4, stop making it. So sometimes what we have to do is we have to quieten the thyroid gland. So we can do that by two different ways. We can give it some iodine, which are going to kill off part of the cells that are in the thyroid, or we can actually remove it. So the radioactive iodide that we give to patients, it immediately goes within minutes and goes straight to the thyroid gland, and it begins to destroy some of the follicular cells that are causing the thyroid gland to be so hyperactive. We hope that we kill enough of it to return to normal, but sometimes we kill too much of it and they become hypothyroid, and then they are required to have medications to supplement their thyroid. So when I have a patient like this, I always ask myself, what assessment findings would the nurse find that would tell me that this radioactive iodide has done its job? I'm looking for signs and symptoms of the patient to return to normal or to become have hypothyroidism, right? And then looking at those two questions helps me to understand where this patient is. So if they come in and they're tachycardic and they're sweating and they're losing a whole bunch of weight, we may not have gotten enough of the thyroid gland in order to make the person euthyroidic, which means that basically they're normal, okay? We may have gone too far and made the patient hypothyroid, have hypothyroidism, and now they need replacement with levothyroxine. So it's that whole yin and yang thing. We also have something called non-radioactive iodine. This medication doesn't kill the thyroid, but it does suppress it quite a bit. We use this typically before the patient goes in to have a thyroidectomy to kind of like calm it down about 10 to 14 days prior to surgery. There's also potassium iodide tablets. This was a really big deal back in the Cold War times. People would keep these on hand because everyone was afraid that we were going to have a nuclear accident and then we were all going to have our thyroids, like, I don't know, killed. So what this medication does is that you take that potassium iodide and it helps protect the thyroid gland from radiation. So we use this before surgery, and then you'll also see it in some people's bug out bags. Prothyroyacil, also known as PTU. Aren't you glad that they just said, hey, let's just call this PTU? We use it to treat patients with hypothyroidism, and then here's your side effects. Of course, we can go too far by treating the hyperthyroidism. We can cause them to have hypo. Sorry, I'm going to skip too far. Again, very important that we give it the same time of day with relation to meals. If you're going to take it with food today, you're going to take it at this time with food every single day. And then, of course, with this medication, the only thing we want to do is we want to stop it 3 days before the radioactive iodine treatment so that the iodine can physically get to the thyroid. So methimazole, also known as tapazole, is probably the most frequently used medication for patients who have hyperthyroidism. Typically, all of these medications are prescribed by an endocrinologist and are managed by an endocrinologist who's comfortable with the way that the drug acts. This medication tends to be more of a prototype medication than the PTU. We see this one way more in practice than we see the other one. So anyways, you can read over that one. We'll be talking about that one shortly.